Prevention is power. Prevention works when antibiotics fail. Prevention only whips even resistance. This is critical to understand. Prevention only will whip even resistance. What I'm saying here is very simple. If we prevent disease transmission, I don't need to treat the next patient because we prevented transmission from the first patient. I have less patients to treat by preventing disease. So if I can prevent disease, I can save millions. So when we look at the effect of antibiotics, in summary, increased colonization rates are seen worldwide for drug-resistant bacteria, particularly nosocomial pathogens and normal flora, Staphylococcus aureus, C. difficile, VRE, CRE, all these are coming. Patients, when they are sent home from the hospital, often are sent to long-term care facilities. Long-term care facilities are receiving these patients with antibiotic-resistant bacteria, and they have decreased quality of life due to extended treatment and delayed recovery. What this means, though, is that when we're looking at the emergence of antibiotic-resistant bacteria, the nursing home is the front line. Prevention is power. Prevention is critical. Without antibiotics, prevention will still work. So let us work on preventing disease. Now let's just do a simple cost analysis. This is not a very complicated cost analysis, but let's just look at the bottom lines. Prevention is far cheaper than treatment. When I look at the cost of diagnosis and follow-up, first I have to prescribe the disease, prescribe the treatment. So I have to pay for that. Then I have drug delivery, charting, multiple reimbursements. The paperwork sometimes on a simple reimbursement can become quite complicated, and this is a hidden cost. The cost of an empty bed if the patient has to be discharged from the nursing home to be admitted into the hospital. $2,000 to $5,500 per month for one patient because the bed is empty and someone else is collecting the revenue from that patient. The cost of isolation of patients, contact precautions. Patients they're social. They're human beings. They want to talk to each other. When you put them on contact precautions and they can't talk to anybody, this is a huge problem socially, but also it is a huge problem financially. Estimate approximately $5 per patient contact to go into a patient's room requiring contact precautions. And then liability. Multi-drug resistant organisms are tracked. They need to be tracked because we need to manage outbreaks, and our tracking is getting to be phenomenal with our modern technology. This is a new and unanticipated source of liability. I can track an infection from the patient to many other patients in the facility, in neighboring facilities. This is a very, very serious problem. This liability is huge and has become much, much larger in the past 3 years. That would take a whole nother presentation to discuss that, but it is increasing and it is knocking on your door very, very soon. You do not want to be the source of an outbreak for a multi-drug resistant organism. Increased mobility is decreased urinary tract infections is the bottom line. If I have patients that don't have drug-resistant organisms and they are healthier, they're more mobile, decreased urinary incontinence, decreased urinary tract infections, and decreased hospitalizations, and then improved mobility resulted in increased decrease of hospitalization for UTIs. You can see the references there. Bottom line is, hospitalization results in lost revenue, and increased mobility of patients equals better quality of life and less expensive care for the nursing home. Now we need to look at defining of urinary tract infections in the elderly. This is a very challenging question. First, I have to be realistic here. I am a microbiologist. I am not a medical doctor. If you want to diagnose and treat patients, see a medical doctor. I'm just going to talk about a couple of articles that I read written by medical doctors about treatment of patients. Okay? In reality, and this is a sad reality currently, we have no diagnostic criteria to accurately identify patients needing treatment and those not needing treatment for urinary tract infections. We have diagnostic criteria, we use them, but we have not verified them, and we honestly can't say that they are scientifically the best ideal diagnostic criteria. Diagnosis also in the elderly patient is usually nurse-driven because these patients often are presenting in a confused mental state with decreased mental faculties, which means the nurse is the one saying, how is the patient feeling? When to treat when a patient is not catheterized, the diagnostic criteria are quite simple. They say do not treat asymptomatic bacteriuria. What this means, if I have bacteria in the urine and the patient has no symptoms whatsoever, this is a common problem in elderly patients and probably should not be treated. Acute confusion without other symptoms is not diagnostic. What we're saying here is often nurses will notice a patient presenting with confused symptoms and then suggest maybe they have a urinary tract infection. That's not sufficient for diagnosis. You need to have more than one diagnostic criteria met. It's a difficult problem as it still may be a urinary tract infection that may be serious for the patient. We do need to treat symptomatic bacteriuria, acute localized genital urinary symptoms, and either acute dysuria, acute confusion, or chills, and at least one of the following or worsening genital urinary symptoms: urgency, frequency, suprapubic pain, gross hematuria, costrovertebral angle tenderness, or urinary incontinence, and these are known as the Loeb criteria. As noted here, they are not yet validated, and thus these are the criteria we use. These are the current medical standard, but I can't prove to you that this is the best approach. Okay? Some patients also present with pyuria, which is basically immune cells in the urinary tract along with the bacteria. Elderly are often unable to tell you how they are really feeling. Okay? So when I look at a patient presenting with a urinary tract infection and they have immune cells in the urine, some people say maybe you should not treat them because they don't have other symptoms. But would we really accept this if we had an abscess on our skin and I had pus? Would we really accept non-treatment of a oozing pus abscess on the skin? For the most part, most of us would not accept that. And so if we look at a healthy hand, we wouldn't treat that. If we look at a healthy hand with an obvious wound, no treatment seems okay. We've all cut ourselves on the cutting board. The hand will heal up. Give it a couple of days. But we've all once or twice in our life been in that position where we got our hand and, well, it was turning into a nice oozing pus mess, and we wanted to go see the doctor. Would we accept non-treatment of this kind of a wound? Not really. So when we look at this, although many diagnostic criteria say that you don't necessarily need to treat bacteriuria with pyuria, I don't really agree with that stance because I think we need to compare that to our own hands and say when there's an inflammation in the presence of bacteria, probably we really should treat them. Okay? When to treat with a catheter. The bottom line is catheterized patients often have bacteria in the urine. The catheter itself is easily colonized by bacteria, and thus when we look at long-term catheterized patients, they often have bacteriuria. Okay? So acute confusion, again, without other symptoms is not diagnostic. Some papers say that catheters, quote, quote, always have bacteriuria, and this is not entirely an incorrect statement, particularly if the patient's been catheterized for very long. But you do need to treat them with fever, acute diffusion, new costrovertebral angle tenderness or rigors if they have symptomatic bacteriuria. Okay? Bottom line, with the current trends in multi-drug resistant bacteria, culture the patient. I cannot emphasize this point enough. We have been blessed for the last 50 years with this miracle of antibiotics that have allowed us to simply say the patient's sick, let's treat them. When we're dealing with multi-drug resistant bacteria, that no longer works, because I can't tell you that the antibiotic we're using works when we have multi-drug resistant bacteria in the patient population. And antibiotic resistance is increasing. Routine culture is becoming more critical, and we need to have culture prior to the onset of treatment. Obviously, with cooperative patients, a clean catch specimen is quite easy to get. Women, an in and out catheter, or men, a condom catheter and leg bag can be used. But we need to culture the patient, because that is the only way to know if the antibiotic we're using will treat the bacteria that grows in that urine culture. As far as treatment, I'm not going to discuss treatment because I'm not a medical doctor. This is a table from Dr. Nicole's review on treatment of urinary tract infections. The first line therapy is there with trimethoprim sulfa, nitrofurans, and such, and other treatments that can be used. And if you want to get treatment of a patient with a urinary tract infection, please see a doctor. Okay?